So good morning, good afternoon, and good evening, wherever you are. I'd like to welcome everyone to our launch of the stage working group documents, the global position paper and the implementation strategy for KMC. And this guidance has been developed on advice of the WHO stage, which stands for the Strategic Technical Advisory Group for Maternal, Newborn, Child and Adolescent Health and Nutrition. This group comprises external and independent, renowned global experts who provide strategic and technical advice to WHO on global priorities and emerging issues to help member states in reaching relevant SDG targets, and also the group reports directly to the Director General of WHO. One of the many ways that the stage contributes to advancing this agenda is by looking into priorities that are likely to have a major impact, looking at interventions for which there is evidence, and also interventions that are likely to become available and address difficult problems that would benefit from bringing different stakeholders together. The stage recognized in 2021 that KMC was a priority intervention that needed to be scaled up, and therefore convened a KMC working group to look at how to scale up KMC, which had been underused. We know that a couple of years ago, KMC had only been scaled up to 5%. And so despite the strong evidence base for the effectiveness of the intervention, it was really important to look at how to scale this intervention up. And so the stage working group brought partners together to facilitate consensus and acceptance of the strategies so that governments and partners can act in a harmonious way to maximize the impact. This webinar, over the next 90 minutes, will look at the two documents. We will present the two documents. First of all, looking at why these papers were required, who the partners are, and what the process was, along with key highlights such as what is important and what is new and why, what are the implications of this new guidance for health services, for providers and healthcare workers, as well as for parents and families. We will have a panel of Ministry of Health focal points from different countries who will discuss the implementation and scale up of KMC in programmatic settings, what their own experiences have been and what will be required and to scale up. And this will then be followed up by a panel with global partners who will tell us of their own plans to support countries in these efforts. We will then close with a discussion on how to take this work forward and have closing remarks by the stage chair. So with these introductory comments, I'd like to hand over to Dr. Rajiv Bahel, who was a colleague of us in our department and spearheaded this work over many years and is now currently with the government of India and is the secretary leading the Department of Health Research and the Ministry of Health and Family Welfare, and is also the Director General of the Indian Council of Medical Research. Rajiv, welcome. Nice to see you again, and over to you.
Thank you very much, Anshu. I cannot start my video because the host has stopped it. Can you please, you want me to start the video or? Yes.
There it is.
Okay, perfect. Thank you very much, Anshu, and a great pleasure indeed to be in this webinar on, I think, on the release of these documents, which is very close to my heart. And indeed a great pleasure to introduce why we took this journey on and why did we go to stage with this. Why we went to stage is because of evidence that was generated between 2015 and 2021. In 2015, we knew a few things about KMC. The biggest one was that it improves survival of stable babies by 40%. But it was recommended by WHO for about 2 decades, and yet there were some gaps. And the most important gap perhaps was that the global KMC coverage was low at maybe less than 5% at that point in time. That was the estimate. The second thing was that KMC was to be initiated only in hospitals because the evidence came only from the hospitals. And the third gap was that KMC was only done for stable babies, but most deaths in preterms and low birth weight babies happen before they can actually be stabilized. So to answer these three questions, the Department of Maternal, Newborn, Child and Adolescent Health at WHO took a research initiative which had three prongs. The first one was answering the question through implementation research as to how to achieve high coverage at scale. The second two questions, the other two questions were answered by randomized controlled trials. The first one answering the question whether community-initiated KMC would also save lives. And the second question, does KMC started immediately after birth would save even more lives than that started after stabilization? So to address this, the first one was IR conducted in Ethiopia and India in over 8 million population, led by Ministries of Health at national and regional levels. The intervention was iterative cycles of optimization of an implementation model of KMC. And the result was that 53% to 82% of all children in the entire district, in the entire 8 million people who should have received KMC, actually received KMC, not only received that, but received it for more than 8 hours of skin-to-skin contact per day and exclusive breastfeeding. So it was not just KMC, but high-quality KMC. So the result is that it is feasible to achieve high coverage. And that was one of the major reasons why we went for the two documents that are being released today. The second was the community-initiated KMC trial that showed that KMC, which was initiated in the community, was 30% lower neonatal mortality than the control group. There's a typo in the intervention. But yeah, it is initiated as soon as possible, but it's not a typo, but it is compared to routine care. So this means that we could achieve impact of KMC even when it was initiated at home. The last one was even more transformative. This trial showed that KMC initiated immediately after birth in a mother newborn ICU reduced mortality by 25% compared to standard KMC. So it was KMC compared with KMC, but with at that time what was considered standard KMC after stabilization, there was a 25% further reduction in mortality. Next slide, please. So when we tried to look at this evidence and said, how many deaths were we preventing in, let's say, 2015, when we were having 5% coverage and let's say 40% reduction in mortality in stable babies below 2 kilos, which was the recommendation then. The estimate is about 10,000 deaths averted in the entire world. However, if we could take the lessons from the implementation research and actually scale up KMC to achieve 60% coverage in the same babies, less than 2 kilos, and assuming a 40% reduction, we would increase this 10,000 to 150,000 deaths averted. Now, if we were to add the impact of community-initiated KMC research, which meant that we could further increase coverage from 60 to 80%, including that, and also, and that the results showed that even the babies between 2 kilos and 2.5 kilos had an equivalent or larger reduction in mortality. And this 30% reduction added to 80% coverage would mean that we could save 250,000 babies per year. And if you were to further add on to that, the impact of immediate KMC research, which basically meant the same assumptions as before, 80% coverage, 30% reduction of mortality in all stable babies below 2.5 kilos, plus 80% coverage of immediate KMC and 25% reduction in those born less than 1,800 grams, which was tested in the trial, then we could go up to 400,000 lives saved per year. So while this impact was considered to be possible, when we took it to the MNCAH stage, the group there, chaired by Dr. Betty Kirkwood and Dr. Michael Merson and Dr. N.K. Arora at that time, thought that we should take this forward and do something with this to build consensus on approaches for implementation among all stakeholders to maximize impact. Next, please. So these are the partners in this effort. As you can see, there are UN agencies, including UNICEF, World Bank, and WHO, bilateral agencies like USAID, Japan International Cooperation Agency, NORAD, and Foreign Commonwealth and Development Office of the UK, donor organizations like BMGF, SIF, and Laerdal, professional associations and non-government organizations, including American Academy of Pediatrics, FIGO, COIN, IPA, Kangaroo Foundation, International Confederation of Midwives, Médecins Sans Frontières, Save the Children, etc., and parent organizations and specialized partnerships, which are shown here, and various scientists and experts from different institutes of the world. So, as Anshu said, the stage decided that we should have a KMC working group, and I just showed you the constitution of that. 2 chairs were designated for this working group, who will be speaking just after me, Professor Gary Darmstadt and Professor Betty Kirkwood. WHO served as a secretariat of this group and with a wide global stakeholder, which were shown in the previous slide. Consensus on the process of development of deliverables was achieved through virtual meetings and email correspondence. Draft outline of the working group documents were agreed through broad discussions, various meetings on content to be covered in the global position paper and implementation strategy. So that was the decision that 2 documents would be prepared, a position paper as well as an implementation strategy. And the content was developed with regular feedback of all the partners and all the participants of the working group, with regular feedback from chairs and all members. There was drafting, review, and edits by WHO Secretariat, and I must here call out Dr. Suchita Gupta, who really did much of the heavy lifting in terms of the work of the Secretariat, the drafting, the review, the editing, along with others who were consultants and other members of the department, as well as all members of the working group. Finally, review and edits were done by all members. All controversies were discussed and resolved, because that was one thing which was thought to be a possible impediment to introduction of and use of KMC to the level that we would like it to be used in all countries. Finally, the documents have been signed off by all the participating organizations and members. So with this, I will hand over to the two chairs, Professor Gary Darmstadt from the Department of Pediatrics, Stanford University School of Medicine, and Professor Betty Kirkwood, who is from the Epidemiology and Population Health Department of London School of Hygiene and Tropical Medicine in the UK, without whose guidance these documents would not have reached the stage they have reached today. Over to you, Gary and Betty.
Rajiv, thank you very much. And thank you for your fantastic leadership on this research agenda and for inspiring the development of these papers. Betty and I are going to talk with you a little bit about what's important and what the implications of these guidelines or these documents are for implementation within countries. Now, grounded in the new research evidence that Rajiv has just described, the WHO engaged in developing new recommendations for the care of preterm and low birth weight infants and launched these recommendations in November of 2022. Within that, there were two very important set of recommendations that really guided our work of the KMC working group. One are these recommendations on KMC, that KMC is recommended as routine care for all preterm or low birth weight infants, can be initiated in healthcare facilities or at home, and should be started as soon as possible after birth. There is another set of recommendations in our next slide that were made around family involvement and support to families in providing care for their preterm infants. Family involvement in the routine care of preterm or low birth weight infants was recommended in all health facilities, and that these families should be given extra support in caring for their preterm or low birth weight infant. And this would include home visits by trained health workers and parental leave and entitlements. Next slide. So then going on, we developed a set of key principles, and beginning with a clear definition of KMC. This was critical for us to have a unified view of what KMC is and how we define it. It's prolonged skin-to-skin contact with support for exclusive breastfeeding or breast milk feeding. We also recognize that KMC features timely transition to lower levels of care within the healthcare facility or to the home with continued skin-to-skin contact and close monitoring. We note that KMC is the foundation of care for all preterm or low birth weight infants, and that programmatically it's nested within comprehensive small and or sick newborn care. This is not a standalone vertical program. KMC places the mother central to the care of her infant and repositions power within health systems to the mother and humanizing maternal and newborn care. Next slide. The mother and infant must remain together at all times, and that combined maternal newborn care should be provided either even when the mother or the infant is sick, and that the involvement of fathers, partners, families is very important to support mothers in providing KMC in health facilities and at home. Immediate KMC after birth is the optimal standard of care, along with other life-saving interventions for all mothers and their preterm or low birth weight infants in all settings. It is not a low resource strategy, but rather it's superior to current high-tech strategies. This is what the evidence tells us. From implementation research, we learned that actions in all health system building blocks are needed for high population level coverage of KMC and for scale up, and that KMC should be implemented at all levels of care, including at home. Next slide.
Thank you very much, Gary. The global position paper that's been launched today presents the evidence and rationale behind the new WHO recommendations and key principles that Gary has just outlined. Our aim in this position paper, it presents a new vision that has been agreed by all partners, where KMC for all preterm or low birth weight infants forms the foundation of small and or sick newborn care within MNCH programs. Our aim with the position paper is to galvanise the international MNCH community and families to come together to support implementation to improve the health and well-being of all small newborns and their mothers and families. Next slide, please. To implement the new recommendations requires a restructuring of maternal and neonatal units. In particular, the layout of small newborn care units, special newborn care units, and newborn intensive care units needs to be changed to enable the mother to be together with her preterm or low birth weight infant, even when they are sick, so that KMC can be carried out alongside other life-saving interventions, such as CPAP. The recommendations can be more readily achieved for preterm or low birth weight infants who are otherwise healthy, since they are usually cared for in the postnatal wards or in separate KMC wards. However, even then, some reorganisation is likely to be needed to accommodate fathers and other family members who can also provide KMC and ensure infants receive KMC as close to 24 hours a day as possible. Next slide, please. Implementing the new recommendations will also require a change in the culture of healthcare provision. We will need to move away from obstetric and neonatal services that are currently typically organised in distinct departments with different treatment guidelines, providers, and locations. We need to move towards obstetricians, midwives, paediatricians, and neonatal nurses working together to create a conducive environment for family-centred small and or sick newborn care with KMC at its core, and also to provide respectful care for mothers and newborns together in one place with families as key partners in the care of their newborns. And we need everyone to accept, endorse, and practice the keeping the mother and newborns together after birth and removing all the barriers to this happening. Next slide, please. Achieving KMC implementation at scale also requires a host of other things. It requires the commitment of political and programme leadership to integrate KMC as part of small and or sick newborn care, requires the development of KMC supportive policies with a national KMC implementation plan, the development and implementation of a monitoring and evaluation framework to track progress. In particular, KMC indicators need to be included in routine health management information systems. To achieve KMC implementation at scale will also require increasing the availability, capacity, and motivation of healthcare providers, creating a functional network of care and improvement of referral transport, and it will require national planning and coordination. Last but not least, it will require adequate and sustainable financing. Next slide, please. The KMC implementation strategy launched today has been written to provide guidance to countries in implementing KMC according to their specific health systems and cultural or social contexts. This is essential in order to realise the full impact of KMC in improving the survival, health and well-being of mothers and preterm or low birth infants alike, and enhancing long-term human capital. Scaling up KMC is central to achieving the 2030 Sustainable Development Goals. There's less than 8 years to go. Action on this is urgent. What is needed is for all stakeholders to come together to turn this vision into reality. We are now going to hear from some of these global stakeholders in the next two parts of this launch. Anshu, over to you.
Thank you very much, Rajiv, Gary, and Betty, for particularly highlighting what the key issues were around KMC, why it wasn't scaled up, but also how we could increase the scope of using KMC earlier on, let's say as part of immediate KMC, but also as part of community KMC, for highlighting what is new in the guidance, and also for highlighting what possible implications there are for Ministries of Health to scale this up. So we're now going to go into a panel with 5 colleagues from Ministries of Health, and I'm going to kick off with Queen Dube, who is the Chief of Health Services at the Ministry of Health in Malawi, and particularly having just listened to some of these implementation issues. Queen, can you highlight for us what Malawi has done and what Malawi will do to scale up KMC? And from your perspective at the moment, what are the most important lessons so far?
Thank you very much, Anshu. Malawi is one of the initial countries that made up a decision to scale KMC. So in all our district hospitals, we do have KMC units, and we were very privileged having been part and parcel of the IKMC trial. And you know, we still remember the faces of those mothers and their families that never really wanted to be separated from their babies, and the mothers that fell under the control arm, shedding tears because there was separation from their babies. Now, doing things in a study setting and then you know, taking it to scale are 2 different things. So what we have on the ground in Malawi is that we have national policies, particularly for the previous guidance from WHO on KMC for stable babies. So at the moment, what we routinely do is KMC for stable babies. We also do quite a lot of community KMC. Now, for us to move to immediate KMC, to routinize that, there's quite a lot that we need to do in the system, starting from review of our policies and guidelines, rethinking the infrastructure bit, because we didn't have the excitement that we saw in India, where they had put up mother neonatal intensive care unit. What we did was to bring in beds in the middle of NICU for the study. So we really, so for us, it's figuring out those flow plans, and we're quite advanced in how we move forward with infrastructure for small and sick newborn care, bringing the mother into the NICU. Guidelines, I spoke about it. Financing is one critical part, because sometimes people think KMC is a cheap intervention. No, what we're doing is changing the place of care from an incubator or under radiant trauma to the chest of the mother. Everything else must be done according to the standard. So for us, financing, so we're in the middle of trying to finalize the costing. How much will it cost us? We also need to remember that at the same time, there's a push for level 2 small and sick newborn care, at least 80%. So these 2 things, they need to go together. And then what is a big challenge for us, and we're looking forward to learning from others that have walked this path ahead of us, is how you balance scaling and quality. Because we saw when we scaled up Kangaroo Mother Care in stable babies, we had quality issues. Now, when you bring in immediate KMC, where unstable babies are involved, how do you scale and how do you maintain quality and maintain safety for our babies? So we're going through a phase where we think we need to take it slowly, start with 2 facilities and learn and build as we go along. So really excited to learn from others, and this has come at a time that as a country, we've always been looking forward to such a moment. Thank you, Anshu.
Thank you very much, Queen, and particularly also for highlighting that issue about quality, because we can scale up, but we need to make sure that quality is there. The next example is going to be from Bangladesh, where a KMC was introduced nationwide as a part of a comprehensive strategy to reduce neonatal mortality with very clearly defined coverage targets. And this was done just a few years ago. And we have seen now that KMC coverage has increased. So Dr. Jahurul Islam, who is the Deputy Program Manager for Newborn Health in the Ministry of Health from Bangladesh, can you share your experiences and especially also your thoughts on implementing the new and updated KMC recommendations in Bangladesh?
Thank you, Angshu. Sorry, I was moving from some place to other, and I got some. I was in the garage because of my vehicle issue. Can you ask me the question again? Just I was out of. I was not connected for last few seconds, so I need to hear it.
Sure, no problem at all. So we were just highlighting that Bangladesh has introduced KMC nationwide as part of a comprehensive strategy to reduce neonatal mortality with defined coverage targets. And this was done a few years ago, and we have already seen that there has been an increase in coverage for KMC. So from your experience, and we would really like to hear your thoughts on implementing the new and updated KMC recommendations in Bangladesh. So about providing KMC also to the unstable newborn, so IKMC, and also reaching the community with KMC.
Okay, thank you, Angshu, for the nice, pertinent question. First of all, thanks to the organizers and WHO and all the partners and all the ministries for arranging such a timely webinar after the IMNHC 2023. Actually, KMC is what should I say? Is a psychological approach. I would rather say it's an approach which is very much related with passion, emotion, empathy, right? So this has got nothing to do with that sort of machines like we do in NICU, in SCANUs and other intensive units. So we have established 400 plus KMC corners, KMC centers throughout the country. But definitely, I have no hesitation to admit that we are genuinely struggling about its service utilization, because definitely we are having community awareness. Will be much more easier to reach out to the people, to the community people, as because the revised protocol is saying that as soon as possible and as long as possible, right? It is not putting any bar. Angshu, when you put a bar like that, you have to maintain it at least 20 hours, at least 18 hours plus per day. And like I said in the IMC, that this should be termed as KFC, that is Kangaroo Family Care, not Kangaroo Mother Care, because we're putting all the burden to the mother. And in our country, people are really hardworking. Mothers have got a lot of things to do apart from giving KMC. They have got other kids too. They have got a lot of household things to do. So this is really very tough on their part to maintain that much of intimate KMC throughout such a long period. So the new WHO recommendation will definitely help us and actually create more enthusiasm among the people that anyone can give it, and definitely as soon as possible, as long as possible, with exclusive breastfeeding, of course. And now we are trying to accelerate the pattern of KMC in the form of IKMC as quick as we can. And we are also having our studies on board, having our piloting on board regarding MSCANU, so that the vulnerable, the critically sick newborn who also requires KMC at the same time, apart from intensive care, so that the mother can be at the side of the newborns and they can provide the KMC as well. So our two important agenda now is IKMC and MSCANU, because MSCANU, you have asked me that what we are what we would do with what we are doing about the unstable newborns, right? Who requires KMC as well. So Kangaroo will be a game changer, as because there are lack of waiting spaces for the mothers. So and they feel that I got disconnected from my kid when he or she is within the intensive unit, right? And when a mother is having her kid in her lap, she will feel more connected. So Kangaroo and IKMC will definitely put on the put on the just push the accelerator button even more stronger. And I guess that our awareness program is ticking on, and with our all valiant partners, UNICEF, WHO, and USAID funded other partners, and ICDDRB, and all the partners of us have side by side the government of Bangladesh, and all other interministerial and stakeholders are also trying to participate in this social movement. This is a social movement, that KMC should be started from the labor room, from where the baby has born. Still, we have a good percentage of home delivery. So, in that case, community KMC is very, very important. So we are actually putting our focus on awareness generation, on implementation of IKMC for implementing the Kangaroo services. And definitely we are 100% aligned with you. We always give emphasis to the WHO new recommendations and guidelines, and hope within very near future, in quick succession of time, we'll be able to actually what should I say, run the show as per the WHO recommendation, both for the preterm and newborn who are stable apart from having low birth weight, and also for the unstable newborn who will be in the special units.
Thank you.
So thank you.
Thank you very much, Dr. Islam, and particularly also for highlighting the issue of additional benefits of KMC, such as, initiating breastfeeding, the close contact, the non-separation of mother and baby, the psychological bonding, and also the fact that it's not only the mother, but actually it should be the family who will take care. So we will next, thank you very much. We will next go to the Philippines. And the Philippines scaled up KMC nationally already during 2014. And as part of this, the Philippines provided social health insurance and benefits for women about to give birth, and extended health insurance packages to include special benefits for premature and small newborns. And that also included KMC as an intervention to address and support premature and small newborns. So we have two representatives from the Department of Health. We have Dr. Maria Lourdes Imperial, or in short, Pinky, and Dr. Faye de Ocampo, who are both medical specialists in the Department of Newborn Medicine at the Jose Fabella Memorial Hospital in Manila. And for both of you, if you can divide your intervention, can you speak to the financial aspects, especially in implementing immediate KMC?
Hi, good evening from the Philippines. With regards to our coverage of KMC, I think the Philippines might be distinct in having a health benefit package for premature and small babies. And this begins from the time that the mother is in premature labor. In preventing the labor, it covers that. If the labor cannot be prevented, we cover the transfer of the mother to a higher level facility. And in case the baby gets delivered prematurely, we have several packages that covers the small baby, 2 to 2.5, and the very small baby, less than 1.5 kilograms. And the different packages will cover for major complications, minor complications. So for the family that is shocked to be faced with all of these things, a baby being in intensive care, the benefit packages will cover for the diagnostics, for the interventions, no, for the medications, everything that the baby needs until the baby is transferred out of the NICU. And then we cover also for the KMC duration of the baby being done, KMC is being done. So we costed everything for the KMC intervention. We costed the daily stay of the mother, the cost of the materials that the baby needs also, and then everything until the baby is discharged. Some of the elements that were mentioned in the implementation strategy are also incorporated into the packages, like it includes discharge planning, it includes gathering data for all of the small babies, what are their outcomes. It requires the hospital to have a referral network of lower level facilities so that we can also refer back these babies for step down care to decongest actually our big hospitals. So we have tried to incentivize the practice of KMC, and those hospitals, no, we want them to level up their care of the premature and small baby, which includes KMC as a service, family-centered care for the baby.
And in terms of scale up, the scale up of KMC in the Philippines was built on the issuance of the National Policy on Essential Care Protocol, which included initiation of KMC at birth. The KMC Foundation Philippines, which helped pave the way for the KMC in the country, offer a complete KMC concept, the regional
Dr. Faye, maybe you can
essential newborn care, basic newborn resuscitation, and KMC were integrated into care for the small babies, which was cascaded to all DOH facilities. Capacity building efforts have led to the establishment of 27 centers for training and excellence and 195 program implementing facilities nationwide by the end of 2018. In 2017, the Philippine Essential Newborn Care and Resuscitation Program, also called the NRPH Plus, developed by the Philippine Society of Newborn Medicine, included KMC as one of the modules. This advocates the initiation of Kangaroo Mother Care immediately after delivery while the baby and the mother are still in the delivery room. And this is intended for healthcare providers who care for the mothers and the baby. And to date, there are almost 6,000 providers trained in the program. From 2018 up to the present, the training of trainers for the care for the small baby continues. And even during the pandemic, to circumvent the restrictions of the pandemic, an online training of trainers course was developed with the support from the WHO, which later on became hybrid with online and face-to-face sessions. Neonatologists, pediatricians, and nurses were trained and are expected to cascade to their facilities. So from 2022 up to the present, there are about 88 trained trainers and 271 providers. And in terms of immediate KMC, we have started with research, including stable sick neonates in the neonatal ICU, even with respiratory support, intubated or receiving CPAP. And the results were encouraging, decreasing the need for O2 support and decreasing the hospital stay. So those were the strategies in the Philippines in terms of scale-up implementation.
Thank you very much, and thank you for highlighting, first of all, the need for referral, but also for a network to refer back, looking at discharge planning, but also the need for training and involvement of professional bodies to scale up the training. Next, we will hear from India, and India has scaled up small and sick newborn care nationally and is setting an excellent example for other countries to really achieve national scale. The landmark immediate KMC study was also conducted in India, which informed the new WHO guidelines. So India has also got already operational maternal newborn care units in a number of places, and more are being planned. So Dr. Shumita Ghosh, the additional commissioner in charge at the Ministry of Health and Family Welfare from India, we'd like to hear from you the fact that you have already achieved national scale with small and sick newborn care. How does India plan to implement immediate KMC, and especially including the mothers in the mother newborn intensive care units?
Thank you. Good morning, good afternoon, good evening. Yes, India already had scaled up the concept of Kangaroo Mother Care because being the most simplest and cost-effective intervention for this sizable population of small and low birth weight and preterm newborn. It is already in the guidelines. We have certain guidelines on promoting this Kangaroo Mother Care operational guideline, then family participatory care guideline. Then we have other guidelines also where MNCU has been propagated in 2018. So all these are in place, and I must say that presently in 979 this SNCUs and 3,000 plus NBSU, as well as 169 MNCU. This is a core strategy for preterm and low birth weight infants. Having said that, I'll quote some data on it. Like we had last year 1.33 million admissions in these SNCUs, of which 25% were less than 2,000 gram weight, and all received KMC according to our online data. So yes, there are gaps. The gaps are in the duration, as well as in the continuation, as well as in the data. So the present guidelines which are there, and of which I was very much a part of it, they will come very handy for us. Basically, what we have to do is to make all our delivery points compliant to this guideline of KMC, which is being released. The barriers, that are there, basically the barriers are making these facilities compliant to KMC, continued, prolonged, and immediate KMC. So the basic problems comes as far as infrastructure is concerned, because already there are 979 SNCUs and many of them have space constraint. So the proposed idea is that wherever possible, wherever feasible, the existing facilities, they will be made compliant. The budgetary supports and other supports are being given. The new ones definitely will come out with MNCU concept where mothers will be accommodated, and this scaling this up, because there is a lot of variation. Though we say that all 90% plus facilities are KMC compliant, there are state-wise variations. So we have to look into those differentials. The next thing is having the second barrier which is there, that is about the various kind of mindsets which are existing in the maybe community, in the populace, and sometimes in the healthcare provider also. So creating large scale awareness, giving the importance how IKMC have proven to be of such benefit to the small neonates and reducing their mortality. So those kind of awareness generation is next on the agenda. Our capacity building of our healthcare workers, that is again a big task at all levels. We have come out with revised ABNC guidelines, facility-based newborn care guidelines. We have come out with NBSU guidelines, which is newborn stabilization unit guidelines. So those training modules, they have incorporated KMC as a core strategy. So giving this kind of training in a wide scale to all our health workers who are involved in newborn care. So that is next in the agenda. One area which is very important is follow-up. Even if in the facilities we are promoting it, but what happens when they go out? So that kind of community follow-up as well as promoting community-based KMC. So that is, again, we have many states have started doing it, and under NHM, the supports are being provided for it. Our peripheral health workers, their modules, basic training modules, they do contain KMC and they do follow up. So that has to be strengthened. KMC can be strengthened in the community. Another important thing is the data issue, because the definition of KMC as it is coming now, prolonged KMC, more than 8 hours at least. So that again, we have to incorporate in our data system, and then we'll actually get who the figures which are getting a KMC, because presently we are getting, everyone is getting for how long, how continuously they're getting, who is giving the care. So these things are also very important. So that system has to be strengthened. One issue is the private data, private sector data we are not getting. So again, there is a gap there. So that also needs to be strengthened, because a lot of newborn are being catered in the private sector. The another major thing is, our packages, PMJY packages, the health packages which are given to economically, socially backward and poor community. So they have 4 such packages for which incorporates Kangaroo Mother Care, support for the mother, their accommodation, their diet. So popularizing them, that is another way out to promote and scaling up of KMC. Having model centers at the regional and state level. Again, having established such centers as models and learning from them, they are again very important. Research, as you mentioned, it is happening and we are promoting it all over the country. Also the transport part, how KMC can be given during a transport, referral transport. So all these issues, they are very important for scaling up our KMC strategy, which is existing already and needs scaling up, so that this benefits of prolonged, adequate, immediate, and community-based KMC reach all our newborn who need them. And we are looking forward to the guidelines, and whatever is needed at the policy level, we are thinking of incorporating all this in our guidelines. Thank you.
Thank you very much, and particularly also for sharing some of your experiences. First of all, you have this wonderful online data system that allows you to really monitor what is happening, but some of the challenges you highlighted around space constraints to scale up, but also the importance of making sure that there is follow-up and how to include this into health packages. And also on the data side, the issue about how to get data from the private sector. So we will now go to our last experience from country level, and that is going to be from Colombia. And we know that KMC is relevant not only in low-income countries, but also in middle and high-income countries. And we know that in many high-income countries, this needs to be scaled up just as much as in other lower and middle-income countries. So we will hear from Colombia, which is an upper middle-income country, and that has scaled up KMC to achieve almost 63% population coverage. And so Dr. Nubia Esperanza Bautista, who's the Director for Promotion and Prevention at the Ministry of Health and Social Protection of Colombia, we would like to hear from you a little bit about how KMC can be taken to scale in high resource settings.
Thank you, Anshu. I apologize, my camera is broken, but I would like to share some slides, please. Okay, so it's a pleasure that the Ministry of Colombia received this invitation to participate in the launch of the WHO Implementation Strategies Guide and the Global Position Paper on KMC. Oh, what happened? Oh, yeah. KMC was not only born with Dr. Ray in Colombia in 1988, but it has been scientifically evaluated since 1989 in Colombia and published in international journals to become an evidence-based method that not only saves millions of lives of premature and low-birth weight babies worldwide, but also guarantees them a better quality of life. In Colombia, premature and low-birth weight infants represents approximately 12% of total newborn. A mapping done last year and presented during the KMC World Congress in Madrid showed that 63% of the 60,000 Colombian premature and low-birth weight infants had access to KMC in 2021. Not only in the hospital where they were born, but also in the ambulatory Kangaroo program that followed them during their first year of life to detect anomalies due to prematurity and intervene in time to avoid sequels. All the 200 neonatal units in the country are trying to include KMC as a routine part of care, and 69 KMC programs are operating in the country. The Kangaroo Foundation has been working for more than 10 years on the scientific evaluation of KMC and its dissemination in Colombia and in the world. Has surely represented Colombia in your group. More than 80 teams from 40 developing countries have come to learn with us, like India, Malawi, and the Philippines. Here with me came to train with us and have successfully implemented KMC in their countries. The Ministry of Health, together with civil society organizations such as Kangaroo Foundation and the Colombian Neonatology Association, has been working for more than 22 years to introduce KMC into public health policies and to provide access to KMC for infants who need it, as you can see in these two slides, the previous and this one. The Ministry of Health has managed to include comprehensive care from premature newborns in the regulations since 2018, sorry. Through the guidelines of the Kangaroo Mother program, these regulations are mandatory through that territory, and there are monetary resources available from the system's country health. Colombia adhered to the WHO position of starting KMC in the delivery room on a continuous basis, and the rule has always been to start KMC as soon as possible and for as long as possible. What is the KMC state of art in 2023? We have a guide of the Ministry regulation, the implantation of the KMC, a definition of the minimum of the activities which must be practiced to obtain a quality care. Two networks between the intra-hospital and ambulatory Kangaroo programs of the country. A network of the pediatric ophthalmologists whose goal is to avoid blind infants due to prematurity, and a national workshop every 1 to 2 years to know the problems of sustainability of the KMC programs and the solutions to be brought on behalf of the Ministry of Health. Here you have the pleasure to see these photos, which explains why the KMC is and remains the ideal tool to humanize the neonatal care, to decrease the mortality and the morbidity, and to guarantee to the premature or low birth weight infant a better quality.
Thank you very much, Dr. Bautista, and for highlighting indeed also this issue of exchange of learning that Colombia has supported, but also how you could use a legal framework to support the introduction of KMC. And so that has brought us to the end of our country panel. And I would now like to hand over to Gary and Betty to kickstart the partner panel. But I have also seen in the meantime that there are a number of chat messages coming up asking people to link up with each other, etc. So please also have a look at the chat, and let's make this a community of practice. Betty and Gary, over to you.
Anshu, thank you. And thank you for these great examples of scaling up KMC globally within countries. Within the KMC working group, we had a number of other organizations coming around countries to support their scale up. This included UN agencies, bilateral agencies, professional associations and NGOs, parent organizations, and academic institutions. We're now going to hear from a selection of these partners, talking about the efforts that they're undertaking to support countries in scaling up KMC. Our first speaker was meant to be Mickey Chopra. I believe that Mickey is having trouble connecting from South Africa. He's been at the International Maternal Newborn Health Conference there. He is the Global Solutions Lead for Service Delivery for the World Bank. I know that personally he's highly committed to KMC, was a very active member of our group, and I'm sure sends his regrets that he cannot be here to share in person their commitment to scaling up KMC as part of primary health care and as a key mechanism for reaching universal health coverage. So we will move on. Betty, I'll turn it over to you to introduce our next speaker.
Thanks, Gary. Well, I'm pleased to say that we do have Hema Marga from the Bill and Melinda Gates Foundation with us. Could you tell us what the foundation is currently doing to support KMC, especially the implementation of immediate KMC? How can you do anything else to support countries? For example, would you be willing to provide funding to set up maternal newborn care units as demonstration sites in a few countries? So lots of questions for you, Hema.
Thank you, Betty, and thank you, Gary, and thank you so much to the WHO for your incredible leadership in this important, really critical intervention. So the Gates Foundation has supported evidence generation and introduction and scale up of Kangaroo Mother Care for over a decade. And this includes the efficacy and effectiveness studies related to facility-based KMC, and more recently, the WHO-led trial on immediate KMC. We are just thrilled that this compendium of evidence generated has led to the new and expansive KMC recommendations that were launched together with an incredibly robust set of comprehensive guidelines for the care of preterm low birth weight infants. So now that the guidelines have been made and has been described today, these are not just small tweaks or adjustments to one intervention. Rather, to achieve the potential impact of the new guidelines, we really, truly have to come together as a community in the following key actions. So one, I think we have to understand that KMC is not a binary intervention with an on-off switch. Achieving impact requires seeing it as a system intervention. Maternal newborn care at every level, from community to lower level facilities to hospital-based care, must be reorganized around the maternal infant dyad. And families have to be provided the psychosocial and instrumental supports that are needed to partner in the care of their newborns. Health facilities need to become places of dignity and respect that families will want to stay. And two, we need to change the narrative about KMC. Too often, KMC is perceived as cheap, easy, and sort of a small thing to be done when a baby is otherwise medically well and convenient. However, I think experience and decades of experience have shown that that is not the case. It is not easy, but it is incredibly important. So rather, we need to situate KMC as a central biomedical intervention, especially within level 2 neonatal care for all preterm low birth weight infants, rich, poor, no matter where you are born. For example, quality KMC needs to enable high quality CPAP provision, and quality CPAP needs to be defined as being provided to a baby in the KMC position. Now that we have the evidence, removing newborns unnecessarily from their mothers at birth causes harm that can no longer be tolerated in health systems. So this requires, as we've heard, culture change amongst our healthcare providers and power sharing with families in a way that breaks down traditional system hierarchies. 3, we need to communicate clearly about this vision of quality neonatal care to align with the Every Newborn Action Plan Target 4, so that the push to scale district level neonatal care subnationally is grounded in a package of clinical care that's organized around quality KMC. Without it, we truly risk empty coverage. Infrastructure is being built every day, and stopping it is not an option. Therefore, we have to support countries quickly in understanding the implications of this recommendation, identify intersectoral opportunities across infrastructure, finance, gender, and education ministries, and partner with civil society actively to intervene promptly. And finally, we have to have courage. We cannot be afraid to fail. We have to fail forward, be practical, start with what we can do tomorrow, use data and implementation science to learn as we go and generate models that can achieve greatest impact, because there likely will not be one way of achieving quality KMC in a system. So at the Gates Foundation, we are supporting many efforts financially and technically at the global level and targeting country level partnership to support these priorities. This includes implementation research, has been mentioned in the chat, the WHO coordinated multi-country implementation research to generate models of immediate KMC, including costing, policy and advocacy efforts, and rigorous implementation with embedded quality improvement. We're truly honored to be part of this collective action. Thank you.
Thank you very much, Emma. That was a beautiful summary. And also, the Foundation has done so much in providing support for the evidence base, and we're delighted that you're carrying on with more funding and support to come. So thank you very much for being part of this initiative. Gary.
Our next speaker is Tedbob Haile Jibril. She is the Chief of Maternal, Newborn, and the Child Health Unit at UNICEF. UNICEF has been very active in playing a leadership role around small, sick newborn care. And as we've been discussing, KMC is really the foundation of small, sick newborn care. And so, Tedbob, how does UNICEF plan to support country-level implementation of KMC within this framework of small, sick newborn care?
Thank you, Gary, and congratulations for all my colleagues who have really worked hard. Gary, for your leadership, Anshu, Suchita, to make this a reality. This was a much awaited document. I have never seen documents so much eagerly awaited. Gary, as you rightly said, UNICEF has been at the forefront supporting countries. So again, in this brief comment also, I would like to reiterate its commitment to ensure that every preterm or low birth weight infant, whether that is in low, middle, or high income setting, will receive KMC immediately after birth, along with other essential evidence-based interventions. And this is to improve not only survival, but also growth, health, and development. UNICEF's current strategy is guided, as you all know, by the Convention on the Rights of the Child and the Convention on the Elimination of all forms of discrimination against women, and in line with the Sustainable Development Goal and the Global Strategy for Every Woman and Every Child. In this strategy, UNICEF is committed to advocate for every child's right to health, influence government's policies, strengthen service delivery, and empower communities. To answer your specific question, Gary, allow me to summarize UNICEF's response along the health system to optimize service delivery across all platforms. As we all know, making this document a reality will require a strong leadership, governance, and policy. And UNICEF, along with WHO and other key partners, has been and will continue to support national, provincial, and district policymakers and program managers, as well as engagement with professional associations to ensure that there will be a dedicated budget for implementing KMC as part of the small and sick newborn care scale up and redesign of maternal newborn service delivery system as needed. Second, regarding KMC supportive policies, UNICEF will continue its engagement to ensure there will be a conducive condition for mother-baby dyad. This requires making the place dignified and that people will choose to use it. And it will allow families to support mothers in providing KMC, incorporating KMC in licensing standard for healthcare facilities and in pre-service education as well. Number 3, in health workforce training and support, UNICEF has been and also continue to strengthen the competency of clinical staff through in-service training, on-site mentoring, to ensure capacity and motivation of healthcare providers. Regarding the service delivery, as you all know, UNICEF has been a lead in supporting governments to develop and construct and equip small and sick newborn units, and we will continue our effort in doing so. Especially in this line, UNICEF will bring its multi-sectoral organization capability to make sure that these facilities have the wash facilities and electrification through solar powers. In health information system also will continue supporting governments and facilities to develop and strengthen the appropriate and up-to-date recording and information system. Last but not least is our gender transformative approach and community engagement to promote KMC. UNICEF recognizes that gender discrimination begins before birth and impedes the realization of rights through childhood, adolescence, and beyond. And UNICEF with a partner will work to address the underlying structural barrier to equality by addressing power dynamics and gender roles. Norms and relationships also at all levels and across the life cycle. Our social, behavioral, and communication strategies and the demand generation approaches are key to unlocking the potential for optimal, appropriate, and timely uptake of KMC services. UNICEF will use the social behavioral communication approaches for appropriate and ethical use of applied behavioral science to the health sector by ensuring its due consideration into policy, design of services, health system strengthening approaches. Finally, I would like to bring to our attention that operationalization and the implementation of this new policy and guideline program guidance will require national level planning and coordination and even subnational level implementation as well. Through its multi-sectoral approach and capability at a national and subnational level in over 190 countries, UNICEF will play a critical role in convening and coordinating key stakeholders and addressing both the immediate and social determinants to ensure accelerated scale up of this effective intervention. UNICEF remains committed to play its role, as we have been saying last week, to aligning together, accelerating together, and saving lives together. I thank you.
Good, Bob. Thank you so much. Thank you for your personal commitment. Thank you for bringing the strengths of UNICEF behind this effort, for highlighting the need for intersectoral actions, for multidisciplinary actions, and ultimately for keeping mothers at the center and unleashing the power within mothers to save their lives and improve their own health and that of their babies. So thank you so much. This is so meaningful to have this support. Betty.
So as we go forward in implementing and scaling up the new KMC recommendations, the support of professional organizations is going to be essential. So our next two panel members represent professional organizations. The first is Jana Patterson, who's the Vice President of the Global Child Health and Life Support at the American Academy of Pediatrics. Jana, we have two questions for you. The first, can you say what support countries can expect from professional organizations such as yours in implementing the new KMC recommendations? And also, can you tell us a bit about how you might plan to support this in high-income countries? Jana, over to you.
Sure, Betty, thank you so much. We've heard today about how deeply Kangaroo Mother Care, or Kangaroo Care, as people have pointed out, has been integrated into policies at the global and national level. But we also know that policies and guidelines are not impactful unless implemented by integrating new practices into our daily work. But this kind of change isn't easy. And if healthcare workers are not convinced of the value of changing their practice, change is really impossible. So over the past year at the American Academy of Pediatrics, we've been organizing town hall events, working in partnership with professional associations of pediatricians, of obstetricians, midwives, and nurses to understand the evidence behind the new practices WHO has recommended for immediate kangaroo mother care. We've gone to Lagos, Brasilia, San Francisco, and soon Karachi, because we know that KMC is a critical intervention when integrated into comprehensive care of mothers and their newborns. Not just in Africa and India, where most of the IKMC trial sites were located, but as you said, Betty, in high-income countries like the United States, where frankly, we've made the mistake of moving away from keeping mothers and newborns together. At these town hall events, we discussed the evidence, but also participated in demonstrations and hands-on simulations of how to implement immediate KMC. Some of you, I hope, may have had the chance to see this in action at the IMNHC conference, where Dr. Chopra still is, that was held last week, where we were practicing IKMC at the technical marketplace, complete with CPAP and IV tubing and mannequins, to really give people a sense of what are the logistics and practicalities of being able to do immediate KMC in a mother-newborn unit. Next month, we're going to launch a year-long echo telementoring program with healthcare workers in Ethiopia, Nigeria, and Pakistan. This learning community will support countries who are ready to make change in their physical environment, as well as their hands-on practice of caring for small, sick newborns and their mother. We'll have a platform for healthcare workers to share their successes and challenges with implementing this new way of delivering care of mothers and their smaller, sick newborns. Personally, I look forward to supporting and learning from these implementation experiences as we continue the journey of shifting from KMC as an isolated intervention to immediate KMC as a whole new way of delivering care of mothers and newborns. Thanks, Betty.
Oh, thanks very much, Jana. This is really, truly inspirational work that you're doing. Please keep going. And please, get other pediatric organizations to join you on this journey.
Absolutely.
Thank you.
So now continuing on, we're going to hear from Karen Walker. She is the president of the Council of International Neonatal Nurses. Now, nurses and midwives are at the front lines and play a critical role in interfacing with mothers and with newborns, and have really, I think, a central and catalytic role to play in scaling up KMC. Now, part of this is going to require changes in people's mindset and the learning that they undergo in order to take on implementing KMC effectively. So Karen, what are your plans to include new KMC recommendations in international curricula for nurses and for midwives?
Thank you so much, Gary, and good morning, good afternoon, or good evening to colleagues around the world. I'm delighted to be here today, and interesting listening to Jana. I actually work hands-on clinically in a tertiary neonatal intensive care unit where I was just a few hours ago. And I completely understand the challenges of trying to implement KMC in an environment where we have so moved away to having technology and incubators. So I'm really pleased to be part of this. Now, we know that healthcare providers are key to directly implementing KMC, as you said, and all cadres of health providers are important. So neonatal nurses, midwife, doctors, but not forgetting community health workers. So we need to make sure that they have the education and resources as well to implement these recommendations. We know, as everybody has said, how critical it is to decrease mortality and morbidity. So I think the first thing that we have to do is we have to make sure that they are widely available and distributed to nurses and midwives globally. And to facilitate this, we will add links to our websites for all these materials and take every opportunity to promote the recommendations through presentations at local, national and international meetings and through publications in our journals. Both ICM and COIN will ensure dissemination of these materials widely to all our members. But our healthcare workers don't just need education and training. As Jana actually said, the most important thing is they need to understand the value, as this will ensure acceptance of the recommendations and integration of the standard of care for all preterm, small or sick newborns. If they don't understand why their KMC is important, it won't get implemented. So we need to integrate it into education programs for all our healthcare workers. My colleagues at ICM advise that KMC is already part of the midwifery scope of practice, and it is the same for neonatal nurses. But we need to ensure that these new recommendations are now integrated, and ICM will ensure this through their midwifery educators in their 6 regional professional committees. COIN will also integrate the recommendations through our COIN Education Committee and ensure the education resources that we have available on our website reflect the recommendations. Last month, we launched a neonatal community of nursing practice funded by the Bill and Melinda Gates Foundation in 4 countries in Africa. And this report's coming out just now is timely as we can integrate these recommendations into all our education and teaching curriculum through the community of nursing practice. However, we also need to ensure the recommendations are integrated into curriculum taught in academic institutions. So for me in Australia, it would need to be integrated into the neonatal courses that are being taught and implemented by the clinical nurses and midwives working directly in the hospitals, as we know they're the ones that facilitate and support the mothers in the postnatal and neonatal units. And this will be our challenge, to ensure that those working clinically in countries will access, will read them, and will be able to action them in their own settings. So we will share with our national organizations, who will share with their universities, and we will facilitate this. Another strategy, which we will look at from different countries, and I took my own from Australia, is that the Australian College of Neonatal Nurses has an education special interest group with clinical educators from most of the neonatal units in Australia. So this provides us an opportunity to connect with clinical educators working directly in the units, and we will target these along with some other strategies. Now, although there are challenges with health systems, infrastructure, environment, and even the culture in our NICUs, we must learn from those who are doing well, both in the low-income countries and the high-income countries. We know from the launch of the Born Too Soon Decade edition last week that every 2 seconds a baby is born preterm and every 40 seconds a preterm baby dies. Implementing these recommendations will save lives, and we will all work to ensure that everyone who cares for a newborn, especially a small and sick newborn, understand the importance of KMC and that mothers and babies must remain together. Families are supported, and KMC becomes our key model of care, even in our high-income countries where it seems very challenging. Neonatal nurses, midwives, doctors, and all healthcare workers and parents have key roles to play in advocating for the scale-up of KMC in our own small parts of the world. Thank you.
Karen, thank you for highlighting the critical role that nurses and midwives are going to play for the integrated way in which you're viewing their education and them leading the implementation on the ground and bringing mothers and babies together, keeping them together, and bringing that point of view and inculcating it throughout the system. So thank you very much.
Thanks. The other group that has a really crucial role in all of this is, of course, mothers and families. And we were very pleased to have on the working group, Silke Marder, who is the chair of the executive board of the parents' organization she co-founded, which is the European Foundation for the Care of Newborn Infants. Silke, I wondered if you could share with us what role you think organizations such as yours can play in supporting awareness among mothers and families and encouraging a civil movement to help accelerate getting these new recommendations into practice. Silke.
Thank you very much for the nice introduction. I also would like to thank you and Gary, but also Anshu and Shuchita to have us here at this panel, giving us a voice, but also being very actively involved in the whole process, because it's important that healthcare professionals, policymakers are not talking about us and for us. We want to talk, we want that you talk with us, and we also want to talk ourselves. And this was really one of the best practice examples I have experienced the last 24 years. And to come to your question, so our parents and parent organizations, they play really a key role in raising awareness and their even community, in their peer groups, and also in the public and the policy level. Just think on World Prematurity Day, November 17. This was founded from EFCNI and a couple of parent organizations in Europe. And when you think on World Prematurity Day, it's a global movement in the meanwhile, not only between parents. We could achieve that all parent organizations, healthcare professionals, and policy makers are working together to raise awareness on the prematurity issue, but also working together for a common message. And we also will have definitely on the next World Prematurity Day the topic about immediate kangaroo mother care. And this is something where we can play definitely a key role. Also in the translation of messages, we have, for example, this campaign in 42 languages. We work together with healthcare professionals to really raise awareness, and this can only be done in their own national language. So we can in Germany not raise awareness with English. So this is also where our parent organizations all over the world have supported in translating messages. And also we are working already on messages for this position paper, spreading the message, what is important also about the recommendation which was published last year in November. What our parent organizations have, what nobody else have, is the direct contact to the peer group. And this takes place in the meanwhile via social media. They are working with media and press and also with policymakers. Several of our parent organizations have changed laws on very a high level, so they are playing really a key role. Some examples are that many organizations have achieved that maternity leave is longer for the ones who have a baby born preterm or sick. And this is important because how should Kangaroo Mother Care really proper work when we have not access to our babies in the times of COVID, for example? That was also a law what several of our parents changed to have access to them. And when we not have maternity leave, where the parents can be in the hospital, provide breast milk, and provide in the end KMC. What is also important that these stakeholders, the parents, share their story. So it's the emotional part. We are open our heart and our private story to raise awareness, to put about all these numbers, what, for example, Karen just mentioned, how many babies die, how many babies are born preterm, putting a story behind, putting a human being, a family, and making these numbers really visible. And that is very important to understand that behind each of this, every second is a family, is a baby born preterm, a destiny, and also visions you had for your life. And you can't realize this because maybe then you're one of the 40 seconds that the baby then die, and then everything change. What also have our parent organizations achieved, and this is where we are pushing a lot forward in the future, is changing, as just Karen said, the curriculums. Many of our parent organizations have achieved already the goal to change the curriculums. Also EFCNI have pushed forward in the neonatology curricula in Europe to put Kangaroo Mother Care putting infant and family-centered developmental care in the curricula of when you want to become a neonatologist in Europe, you have to follow this in your education. And what is also important to understand that a group like ours, EFCNI, has established in the meanwhile over 120 parent organizations around the globe. We are working hard for low and low middle incomes. I was also in South Africa last week and could make a lot of network to achieve this goal, not only in the high income countries where we struggle often to have the parents involved because we have incubators and other technical equipment to bring these babies to survive, but having a voice, not as a white blonde woman from Germany in this community. We need the people in each of the countries in the world. And this is also important to collaborate and work together and spreading the message about this position paper, but also about the guidelines to convince the people, to convince the decision makers. And here can parents play really a key role.
Thank you very much. I mean, this is also very inspirational work and great leadership from you in it, but also the way that it's expanded to organizations all over the world. This is amazing. Thank you.
Thank you.
Thank you very much. And that was another amazing panel. And we had so much to share that we're actually running a bit over time. So I'll sum up a little bit about what next steps could be and how we can work together. We've already seen that Ministries of Health are really in the driving seat, scaling up. We've heard so many good stories from the 5 Ministry of Health representatives, or 6. We had 2 from the Philippines. The 6 Ministry of Health representatives, how KMC is being scaled up, integrated, how resources are being made available, etc. And we've heard how partners are willing to support our Ministries of Health in moving that forward, whether it's a UN agency or whether it's a parent or patient organization, a civil society, or a professional organization. So we're all committed to this. We were around 650 people, over 650 people on the call. And so I think we're all gung-ho, let's say, to move this agenda forward. So, but this webinar, of course, is not where it ends. We know that it's important that we achieve quality standards. We know that it's important to monitor the implementation of KMC. We know it's going to be important to make sure that facilities are really restructured or reorganized according to maternal newborn units, so that there can be a rooming in of family members together with the newborn to make this really a reality. We're looking at identifying a coverage indicator in relation to KMC so that can be included in routine health information systems. We're also looking at, let's say, how to support families and communities and responsive caregiving. We also launched last week the updated Essential Newborn Care course, both Module 1 and 2, let's say, and that also includes modules on KMC and essential care for the small and sick newborn. So some of the work that is going to be taken forward is the development or the revision of the KMC practice guide, which will really be an operational guide for healthcare workers. The current one is from 2003 and therefore really needs to be updated. We're also going to see how our immediate KMC implementation research will help us guide on what kind of infrastructural changes are required in order to scale this up. So just maybe summarizing a little bit also that advocacy is also needed and multi-partner dialogue is needed to really drive the implementation of KMC and how to scale this up. We will be developing technical materials, packages, toolkits for setting up new maternal newborn care units and adapting or converting existing newborn units to maternal newborn care units. This was one of the challenges also highlighted by India. So Finally, I would like to hand over to Caroline Homer, the chair of the stage, to make some closing remarks.
Thank you so much, Anshu, and thank you to everybody. What an amazing afternoon, morning, whatever your time zone we've had today. As the chair of stage, I'm so delighted to see this work launched today. As Anshu described at the beginning, the KMC working group was constituted by stage as a new way of working, and I think you can agree that it's been incredibly effective, engaging, and productive. And it's been a really good way of bringing together a whole lot of people to address a difficult problem that needs to be scaled up, that needs to be implemented. We have the evidence, we have the enthusiasm, we just need to work out what to do next. And I think these documents today and the country examples are really critical, that there's no one size fits all. There's lots of different ways to do this, as you've heard today. And it's been very exciting. The process engaged a range of stakeholders to come together to reach consensus and to formulate the way forward. And particularly great to have the parent groups, as Silke explained at the end, involved in this work. And we really want to harmonise actions for scale up and maximise the impact. I think we know this intervention can be effective, hugely effective, and save lives. We know it needs collaboration. We know it needs ownership, commitment, policy leadership, and financing. I'd like to say a huge thanks to all the team who contributed to this work. Many of you have heard from them today. A particular thanks to the stage leads for this work, Betty and Gary, but also to all the WHO team, the Secretariat, Shishita, Anshu, everyone who played such a significant role, and of course the researchers who provided the evidence that enabled us to do this work today. Thank you to all the presenters, really thank you for coming together. This new guidance can now be used to make a real difference to mothers and newborn in every country. We can all start something today. We don't need to wait anymore for anything else. We've got the evidence, we've got the guidance. You've heard the stories. I think we can get onto it and really make an impact. So thank you for joining us on this important journey. Really an exciting day for all of us. So I'm going to hand over to Shishita now to finish the webinar.
Yeah, thank you, Caroline, and thank you everyone for joining. We will share all the key materials, including the 2 documents, the global position paper and implementation strategy, along with all the relevant materials with you soon after the webinar. We also have an accompanying Lancet comment on this launch, which summarizes the key messages, and we request you to not only use these materials, but also disseminate them widely within your networks. And without further ado, I would just want to show you a very brief KMC advocacy video, which you can use further for dissemination and advocating for this very key initiative.
Globally, 1 in 10 babies are born too soon, before 37 weeks of pregnancy. Many more have a low birth weight, under 2.5 kilos. Survival is poor. Complications from prematurity are now the leading cause of child death worldwide. But new, high-quality evidence shows that a simple technique has the power to save the lives of hundreds of thousands of these babies every year. Kangaroo Mother Care includes continuous skin-to-skin contact between a mother and a baby, held securely in a sling or wrap for as many hours in a day as possible, and exclusive breastfeeding. WHO recommends Kangaroo Mother Care as the essential standard of care for all preterm or small babies, both well and sick, starting immediately after birth. It has been shown to save lives, reducing infections and hypothermia, and improving feeding. It provides immense benefits compared with the common current practice, whereby small or preterm newborns that require specialized medical care are separated from their mothers and caregivers inside a newborn care unit. So here is how you can help ensure every small and preterm baby gets the skin-to-skin contact they need from the moment they are born. Mothers can provide Kangaroo Mother Care for their babies, starting immediately after birth. Fathers, partners, and family members can provide help and relief, stepping in when mom needs rest. Facilities and health workers can help ensure mother and baby stay together right after birth, even when the baby is sick. For many facilities, this will require a radical shift in the way care is provided so that mother and baby receive medical care together in one place, even if the baby is sick and needs intensive care. Governments should recognize and fund Kangaroo Mother Care as essential for all preterm or small babies. Kangaroo Mother Care can revolutionize how we look after small and preterm babies. Let's make sure every baby gets the contact they need together from the moment of birth.
Thank you very much, Suchita, for also showing us that video. I think it was a wonderful illustration of what is possible, what needs to be done, that even with CPAP, you can still do Kangaroo Mother Care. And so I would like to thank everyone for supporting us and taking this work forward, all the partners and everyone. Thank you very much for joining us today. I hope that you'll be able to download all the resources that Suchita has mentioned. We will share it also by email. And I hope that you'll be able to advocate for this and make it a reality wherever you are working. Thank you very much.
Thank you, everyone. Thank you.